Good afternoon, everyone. I know people are just joining into the room. It takes a moment or two for the system to catch up and to let everybody into our virtual space. As we come together, I want to welcome you here. My name is Warren Mabey. I'm the director of the School of Policy Studies and an associate dean in the Faculty of Arts and Science here at Queen's University. And on behalf of my colleagues, I'd like to welcome you to this session. I will be handing over the chair of the session to David Walker, my predecessor. But before I do, I wanted to take a moment to acknowledge that Queen's University is situated on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. It is a privilege for us to be able to work here and to study here and to gather here. It is a place where over many millennia, people have come together to exchange ideas and to form community. And I like to think that Queen's carries on that tradition. And that's what we are trying to do today, helping to build a community and to provide a forum for exchange of ideas. This is the third in a series of panels that we have assembled related to COVID-19. I don't think we ever anticipated it would be quite so many, but I'm delighted that you're able to join us. And I'd like to introduce David Walker, who is the former director of the School of Policy Studies and a former dean of the Faculty of Health Sciences, to run this session. David, over to you.
Thank you very much, Warren, and welcome to Queen's School of Policy Studies COVID 3.0. I'm delighted and grateful to be joined again today by three wise and thoughtful physicians, all of whom play and have played an enormous role in pandemic policy at the local, regional, provincial, and national level. I won't embarrass them by delineating their impressive CVs. They're all stars in the Queen's galaxy. But in brief, Dr. Samantha Buttemer is a new generation leader in public health, health system transformation, and education. Dr. Gerald Evans is a clinician scientist and a Canadian leader in infectious diseases who you might see in hospital if you get COVID. And Dr. Kieran Moore, whom you may have seen in a previous incarnation when he worked with me in our emergency departments, is also a Queen's professor. And we're so proud that he's now Ontario's Chief Medical Officer of Health. Thank you all for doing this. Just a few introductory comments from me, and then we will move to our panel. It's now 2 years, as Warren said, since the four of us in this very forum, but then in person, first addressed the impact of SARS CoV-2. In those 2 years, our society has experienced significant but necessary collective restrictions on our individual freedoms in order to protect the vulnerable and the integrity of our healthcare systems. 2 years ago on this date, Canada had few cases of COVID-19, and some of us pontificated, particularly me, that we had learned lessons from SARS that would make us better prepared. Last year, we met again, and there were expressions of chagrin, at least from me, on the preparedness prediction, but a clear sense that non-pharmaceutical, that is public health interventions, were highly effective, albeit at a significant cost, requiring justifiable deployment. And we recognized that remarkably effective and safe vaccines were showing us a way forward, evoking a lot of optimism. Meanwhile, COVID has caused great fear and many casualties. The elderly, the marginalized, those with mental illness and addictions, and the caregivers, and indirectly, of course, our businesses, our economy, and a generation of our youth who've been deprived of many aspects of their education and social development. This pandemic has exposed and magnified the shortcomings in many of our public policies and institutions, especially in how we provide health and social care. Our sense of instability and uncertainty, I think, is magnified by the roller coaster of pandemic waves and resultant restrictions, and by the rapidly evolving knowledge and evidence that guides decision-making, by the misinformation that thrives in this milieu, and by the experience of odd disjunctions, watching the Leafs play to a full house in the US one night and an empty one in Toronto the next, seeing that Holland, France, the UK, and Denmark are lifting nearly all imposed restrictions, yet numbers of infections seem high everywhere. Some are worried about the safety of our schools, colleges, and universities. And while our hospitals are just coping, they are full and backlogs of urgent interventions grow larger. So now, today, we gather once more to separate fact from fiction, to allay fear, to consider the virus we've come to know so well, the human immunological landscape that is now so very different, the public health policy trajectory we have pursued, and to provide a reckoning of the balance sheet of the benefits and costs of our efforts. Gerald will provide the latest information on our virus. Then Kieran will discuss pandemic public health policy, followed by Sam, who will talk about some of the indirect and direct effects of the pandemic looking to the future. For those with questions, and I hope we'll have time for some questions and answers at the end, please use the Q&A at the bottom of your screen. And we will try to be done by 1 o'clock because I believe Kieran has a press conference where he's going to make some portentous statement to the public. So with that said, Gerald, if you could share your screen and we'll hand over to you. We're going to try to stick to 10 to 12 minutes each and then go to Q&A. And I would thank you again for your attendance today. Gerald, you are on.
All right. Thank you, David. I'm going to just get my slides up here very quickly so Chris can kind of pop them up there. I think you're seeing them. If somebody could give me a nod, one of my fellow panelists, just give me a nod. You can see it. I'm just going to go to the big screen so you can really see what we're looking at. So I actually showed this small little cartoon last year because really the challenge has been around the science in that during stressful, anxious times, people are looking for simple answers. Unfortunately, sometimes simple answers can be wrong and complex answers, which are more difficult to understand, can actually be right. And I'm going to try and bring you through what I sort of perceive as highlights of the science, both over the last 2 years and what's recently arisen with our understanding about things like Omicron. So we're going to talk about the virology of variants. I'm going to talk a little bit about transmission issues, talk about the illness itself, and then how effective vaccinations have been, and then conclude with some remarks about treatment. And I brought this up because I had this in a slide deck before that we're really only 3 days away from the 2-year anniversary of when WHO declared a public health emergency of international concern. As everyone knows, though, the pandemic officially was declared on March 11th. So we got lots of these variants floating around, all slight variations on the basic ancestral SARS CoV-2 virus. And I've got Omicron up here in big because, of course, it's the one that we're worried about most now. So, you know, again, a really important thing to remember that variants, you know, why do they happen? And they happen when you have lots of viral replication going on. All viruses make mistakes when they're replicating. It's not their fault. They don't do it on purpose. It's quite accidental. And in fact, most of them are actually mutations that don't do anything favorable for the virus. But if you have enough of them, and it's happening a lot, which is what happens when you have a pandemic and you've got millions, if not billions of people infected, these mutations could lead to these new variants, which have been really one of the challenging things about the pandemic. One of the things that I've talked about before is that, you know, we think that SARS CoV-2 as a coronavirus doesn't actually mutate that fast. But some very groundbreaking work that's been published by Trevor Bedford's lab at the University of Washington in Seattle has actually looked at the fact that SARS CoV-2 may be actually mutating faster than what influenza does, which is really quite fascinating and might explain why over this period of really 2 years, we're now into a fairly significant number of variants of concern that have arisen. I put this up as a question mark because this is one lab's work. And again, what this graph shows you is that when those mutations are happening, the ratio of them happening is more common in S1, which is the part of the gene that codes for the spike protein. And the spike protein is pivotal in our understanding of infection and transmission. Everybody knows that the original virus had a reproductive number around 2.5, which is pretty scary. But then the D614G mutation, which we saw here first in Ontario, had a slight bump. Alpha had another bump, Delta had another bump, and of course, Omicron has another bump. So what's driving all this? Why are these variants of concern got these higher reproductive numbers? Well, the reason that they're more transmissible has to do with viral replication speed, and that's what it's all about. I know people infer all kinds of other reasons for it to be more transmissible, but it's all about viral replication. And you can see with the original virus, Delta and Omicron, you got this incubation period, which was shorter and shorter. And what's interesting is all of the variants show different mechanisms to enhance that viral replication. And then with Omicron, what we've had is that's been tied to an erosion of immunity from either prior infection or vaccination, which expanded the pool of susceptible hosts in the population. So how did they do this? Well, it's really quite simple. Alpha turned down an early interferon response in cells. And you can see here with alpha represented in red that the transcription of RNA for interferon beta was diminished, and therefore they secreted lower levels. That's actually important because one of the things that all of our cells do is they make a lot of interferon early in the viral replication cycle to control the first 12 to 24 hours. So basically, alpha could replicate to 80 times faster than previous versions. Well, then comes Delta. What did Delta do? Delta actually allowed cells to fuse their membranes more efficiently, which allowed the virus to bypass the normal kind of slower cell entry process by forming these things called syncytia, which allowed neighboring cells to be infected more quickly. And in red bars here, you can see Delta. And this is the fusion activity as compared with all the other variants. So a lot of this is understandable from a virological perspective. And all of these led to a shorter incubation period, more virus being present and shed early on in the infection, both pre-symptomatically and with the onset of symptoms. Now, Omicron is cool because it does this even more interestingly. It, of course, has this faster viral replication speed and growth. That may be related to the cells that it actually infects, but a lot of it is related to the erosion of immunity from prior infection. The other thing that this Omicron does is it actually is able to use a wider range of cell receptors than other variants, which makes it look a little bit more like a seasonal human coronavirus. And then we've got this issue of what tissue does it like to infect? And it pans out it likes the respiratory tract or respiratory airways more so than the lung itself. So what is Omicron doing? It's got this immune evasion, so it's got more susceptible hosts around than Delta and Alpha had, because during Alpha and Delta, we had lots of protection from vaccination. And it allows this rapid growth, which is demonstrated in these two graphs, which show the growth of the Omicron variant from South Africa was 3 times higher than Delta. In the UK, it was 5.5 times higher. That allows for rapid growth, a short incubation period, and early and higher viral load peaks, which of course is going to result in transmission in the population. The other thing it does, and this looks really complicated, but it's not, is it's a comparison of Delta and Omicron and the cell entry mechanism. There's this funny compound called Camostat, which blocks this ACE2 receptor entry of the virus into cells. And when you do that to Delta, it basically gives you this really low viral copy line. But if you do it with Omicron, Omicron gets slowed down a bit, but it eventually takes off. So why is that important? Well, one of the things we know of the many things that protect children from COVID, and there's lots of evidence about immunity changes, which are really relevant in kids that you don't see in adults. There is some evidence that this ACE2 expression, which is diminished in kids, had protected them from the early variants, but it's doing less of a job protecting them from getting infected with Omicron, basically because Omicron can bypass that methodology. So we understand a lot about what is this issue about transmissibility with the variants. And then lastly, Omicron infects the lining of the airways more so than the lung. This is some data from the Hong Kong University School of Medicine, in which they showed in blue here, Omicron was able to replicate 70 times faster than Delta and tended to pick on the bronchus, the airways, rather than the lung itself. And you can see these bars in comparison. So this is going from being what was really essentially a pneumonic virus to something that looks a little bit more like a virus that likes to go typically after our airways. And we see that with a lot of the common cold viruses and the viruses that typically produce bronchitis and nasopharyngitis. This is some more data from the same lab showing in red here where the virus is being expressed, and it's on the airway lining of the bronchi, and they use some human bronchus tissues which are obtained from patients undergoing lung resection for cancer. And this is just an electron micrograph that again shows you the viral particles in these respiratory epithelial cells. So a different kind of look at things. Let's talk briefly about SARS CoV-2 transmission. This is probably one of the big bugbears that's out there. I love this cartoon from Michael de Adder. It's all about whales being protected from ships, but the whale is saying, I need physical distancing. Why is that important? The reason it's important is the spread of COVID-19 is really dominated by close proximity transmission. The transmission is multimodal. And when you're in close proximity to someone who's infected, you have heavy environmental contamination, you have direct and indirect contact with virus-contaminated surface and objects, and you have the likelihood that some of these respiratory particles are going to end up on mucous membranes. And of course, there's a higher likelihood of the inhalation of these short-range aerosols, which are in higher concentration, as you can see in this diagram, than they are at distance. So as an infectious disease doc, infection prevention person, my view of airborne transmission is that you're talking about long range over time aerosol transmission. And that has been diminished. And there's emerging lots of evidence now finally to suggest that this is actually uncommon. It can happen, it's opportunistic, but it's this close proximity transmission that dominates with the spread of COVID-19. What other information do we have supported? This is a meta-analysis from the BMJ that was published just a month or two ago, and it showed that hand washing, mask wearing, and physical distancing all had an impact on reducing the relative risk of transmission of COVID. So if this is just an airborne virus, why does hand washing work? Why does a physical distancing work? Because if it's airborne, you could be feet and meters from somebody and still get it. And yes, can that happen? Yes, opportunistically. But this just tells us that it's that close proximity environmental contamination issue that creates it. We know about the famous Swiss cheese diagram. This is something that was reproduced from for the science table here in Ontario. The number one thing, of course, is to get vaccinated, but the other important ones are wearing a mask and physical distancing. These are also important to avoid large gatherings and staying in well-ventilated spaces, but these are the ones that you really need to have in place all the time to get that effective reproduction. Let's talk a little bit about the illness. What determines the illness trajectory? This is actually an easy slide to make because we still are really learning lots. We do know one important thing, but we don't know what is it that leads to most people recovering. What is it that causes more serious illness that leads to hospitalization? That one we have at least one factor that's incredibly important. And then, of course, this big mystery of what are the factors that lead to long COVID. And I just saw a paper this morning that is now examining the long COVID issue and developing some ideas of what the genetics are behind it. The other thing we know is that different variants can produce different illness. Look at Omicron. This is a comparison that was done by the UK Health Security Agency, looking at what were common symptoms with Delta and what was less common with Omicron and what was more common with Omicron. And what you can see here is sore throat, fever, cough, typical of things we see with classic respiratory virus infections of the upper respiratory tract, dominated. And funny things like loss of smell or taste, which was a big thing during the original year and a half of COVID, actually is diminished in Omicron. So some interesting facets of that. We know a lot about the disease course. We know there's an incubation period, which, as I've just told you, can vary depending on the variant. We know that there's an acute phase of illness that typically lasts about a week, and that in some people that can go on to a very significant inflammatory phase, which requires hospital care and complex medications in order to try and affect recovery. So this has stayed relatively constant. However, the contributions of each of these phases to the illness itself is varying, and we now know that variants can affect that, and of course, vaccination to a big degree. This is an old slide which I've kept because it's really important for people who like to say this is just the flu. This is not just the flu. What you can see here in red are infection fatality rates reported for COVID-19. And what you see here in blue is infection fatality rates for seasonal influenza. And at a young age, they're fairly close to each other, but as you age, and when I'm talking age, I'm talking anything over about age 40, the actual infection fatality rate increases based on age. That's a critical thing that we know about, and for where our vaccines have really helped to control things significantly. So basically, COVID-19 has an infection fatality rate that's probably 10 times that of influenza. So this is not just the flu by and large, and it's not a thing that you should be listening to when somebody says that. That's a good segue into vaccination and how has vaccination helped us with COVID-19, and it's huge. This is a great slide I've shown a lot of people, which looks again at age, starting at age 30 out to age 90, in a logarithmic scale of what the sort of lethality is at each of these time points in age. And what this is meant to show you is that age is a huge predictor of lethality. The older you are, the more likely you are to die from COVID. But when you get vaccinated, that can dramatically reduce that risk. This is a log scale, remember. So an 80-year-old with a risk of about 1 in 100 of getting COVID unvaccinated, if they're fully vaccinated, that risk actually drops down to what would be about 1 in 200 or so. Sorry, 1 in 2,000, my apologies. So really that's the effect. All these blue arrows show what happens when you get vaccinated, and that's huge. And, do you need any more data? Well, here's some US and Swiss data looking at death rates by vaccination status in both those countries. And you can see unvaccinated people have a death rate that's, somewhere around 10 times higher in the States than if you're vaccinated with or without a booster. And in Switzerland, it's actually even higher, but probably comparable. So vaccination prevents death from COVID-19, no question about it. The other thing it does is it controls hospitalizations. This is some data from Ontario that we had at the science table, which looks, again, you can see this age gradient in terms of the severity of illness as measured by hospitalization. The gray bars are unvaccinated people. The dark turquoise are 2 doses. And the light turquoise are 3 doses. And what you can see is this enormous protective effect in older people. But even when you're vaccinated, if you're older, there's an issue there that predicts the likelihood of more severe disease. And so when we look at 3rd doses, what are they impactful on? They're impactful on preventing infection. We know that that goes from about 25% with 2 doses up to 60%. And prevention of severe outcomes goes from a good rate at 75% protection with 2 up to 90% protection with 3 doses. And this is data mixed from the UK and here in Ontario. So vaccines work even against Omicron. This is a fascinating study just published in which we look at the issue of, does it also protect transmission events? This is a group from the UK. They published in the New England Journal of Medicine showing that transmission rates among unvaccinated people forward to a contact is about 46%. So that's very close to the 40% we see with households. But if you're partially vaccinated, and I'll look at Pfizer here, particularly in green, that drops to 26%. And if you're fully vaccinated with at least 2 doses, that drops to 21%. This is compelling evidence, that vaccination really reduces risk of even ongoing transmission, not just severity of disease, which we know is enormous from these vaccines. And then just to kind of put the last bit in perspective with vaccines, Canada, a country with high rates of vaccine uptake compared to the continent of Africa with multiple countries, all with different data, but with less vaccine coverage, you can see that the case fatality rate remains about 1% in Africa. Here in Canada, though, it's dropped. And yes, I know there are confounders in looking at this data, but a lot of it can be attributed to the fact that vaccination of the large part of the population reduces that infection fatality rate. So what about treatments for COVID? Very quickly with 2 slides. We've got lots of treatments. This is from a MMJ Living Analysis. And you can see we've got all kinds of medications and treatments available for people with non-severe, severe, or critical illness with COVID. So this is a huge advance in 2 years. And again, we know where to apply them. This basically goes to show, don't use these things. You shouldn't probably use these things, but you should use these things. That's what those recommendations are all about. I put the reference for people to look at it if they want. And here in Canada and here in Ontario, in fact, right here, we are looking at the use of monoclonals, antivirals like remdesivir and Paxlovid, as well as other drugs, which now we have some evidence to support they may be beneficial. But you can see their effect as measured in the number of people needed to treat to prevent a hospitalization. If you assume hospitalization risk is 10%, varies. Some of them are very high, like Paxlovid and sotrovimab, but a little bit less so with an old SSRI, fluvoxamine, or an inhaled corticosteroid. So summing up, where are we? Well, the science of COVID has been moving forward at breakneck speed. But real-time science we're seeing is challenging because, again, it doesn't get to go through a lot of processes where we can show people what matters and what doesn't matter. I think I've showed you that age is the primary determinant of the illness course of COVID. That is the #1 driver. There are other factors, but that is the one that does it. And we still don't yet understand the genesis of other outcomes, but we're beginning to sort of see that. Lastly, we have highly effective vaccines that have diminished illness severity when given, and we have more options to manage at-risk patients should you get COVID and you be in an at-risk group. And I haven't talked about those, but we certainly can identify where those are and who those people are at this point. So my last thing is to point out that although science has really driven lots of this stuff about the 1st, 2nd, and 3rd waves in understanding things in medical care, we're now into this aspect of things. And I think, Dr. Buttemer is going to talk a little bit about what all those are all about and hopefully guide us to all the other health implications of COVID. So I'm going to stop at that point and I will stop sharing my screen. And I don't know if I'm handing back over to David.
Thank you very much, Gerald. We have some questions already, but I'm going to save them. Appreciate, again, your update on this intriguing virus and its effects and behaviors, and turn now to Kieran Moore. Kieran, our Chief Medical Officer of Health, to talk a little bit about the public health trajectory of strategy and interventions that have been proven so effective, albeit sometimes irritating to a few.
Thank you, David, and thank you, Gerald. Always a pleasure to attend these and to get educated, and I'm very much looking forward to Sam's presentation as well. Just to follow with Gerald, from a population health vantage point, public health, we start our day by looking at aggregate population data. So I'll just share with you 73,000 Ontarians got vaccinated on average every day last week. So Gerald, that reinforces they're hearing your message about the strong protection offered by vaccination. 6.2 million Ontarians have received their third dose, and since January 5th, when we had further public health measures, 2 million additional Ontarians came forward to get protected. And we know now the third dose is significantly protective against severe outcomes in the 88 to 95% range. So certainly would love more Ontarians to come forward, but that 2 million since January 5th, I think is a great track record, and want more Ontarians to come forward. 80% of our over 70s are now protected with third doses, 61.9% of those between 50 and 69. And happy also that our children are coming forward. 52.7% of our children 5 to 11 have come forward with first doses, and 13% have had their second doses. So we look at the immunization data on a daily basis to ensure that we're getting adequate protection across populations, that our populations are having accessible and available vaccines because of the data that Gerald just showed of the significant level of protection. And we, as Gerald has said, always use an equity lens to ensure that all Ontarians have accessible and available vaccine. As well, we look at the hospitalization data, because right now we're absolutely concerned about protecting the ability for our health sector to be able to provide care to Ontarians at the right place at the right time. 599 Ontarians are in the intensive care unit who have tested positive for COVID. The length of stay now is 10 days median, and that is tracking upwards. 366 are requiring ventilation. The percentage of all positive tests in Ontario is 14%, which is on a decline. And happily, we're starting to see a decline in overall admissions to hospital at 3,645. And as Gerald said, the risk of being admitted to the intensive care unit, so 10% of our population remains unvaccinated and are eligible, but they have 50% of the beds, sadly, from COVID-19 are taken by immunized individuals. So we have a ways to go in terms of knowledge translation and increasing coverage, but you have a 10 times higher risk of being admitted to the intensive care unit if you are non-vaccinated, a 5 times higher risk of being admitted to hospital if you are non-vaccinated. So those are how I would start my day, by looking at the daily data to ensure that we have data-informed policy decision-making. And we also use the data to do projections and modeling. And certainly in late December and early January, we saw the projections, if we didn't take action, that our health system could have been overwhelmed, our ICU capacity could have been threatened, and we wouldn't have been able to provide the right care. So in a timely and I think proportionate way, we put in public health measures on the 5th of January to protect our health system. It's not to reduce or not to eliminate the risk of Omicron in our population. This virus is just too transmissible. It is to reduce the risk and burden on our healthcare system. So it is a change in our whole strategy over the last 2 years that we have to move from risk elimination to risk reduction at an individual level and at a population level. And we're in a better position now, as Gerald's already mentioned. We've got safe and effective vaccines, high protection against severe outcomes, and the advent of oral outpatient antiviral therapies. Even though they're at a limited capacity at present, we have 10,800 doses that are available through clinical assessment centers now and are being distributed, again, with an equity lens across Ontario. So we have more tools. We have a safe and effective vaccine. So our public health measures should be tapered, should be focused, should be reasonable, prudent, and proportionate to the risk, and hence the reason they're being removed by the 31st. So this is the shortest duration of public health measures that we've had in play, and I hope Ontarians understand that it was to protect the health system. It was not to eliminate the risk of this virus, because this virus is just too transmissible. So at a population level policies, we must continue to have a balanced, proportionate, reasonable, and prudent approach. We absolutely have learned over the last 2 years that there are unintended consequences to all public health measures on our mental, physical, social, educational, and economic aspects of our population, and certainly want to learn from that. Hence the reason I wanted schools to open early, and the importance of in-person learning for our children who have missed so many weeks of in-person education. And hence you'll hear going forward, as we learn to live with this virus, that we must be balanced. We must be proportionate. Yes, we'll be slow and cautious. We'll use all tools available at our disposal, including the Swiss cheese approach that Gerald's mentioned, masking, distancing, hand hygiene, improvement in ventilation in school systems, maximizing access and availability of vaccines, and now the provision of ever-increasing amounts of outpatient oral antiviral therapies, which is again novel, and the supply of those will be increasing month after month after month. So our hope is not to have to put in public health measures. The unknown, though, is this virus, as Gerald pointed out, with the mutation rates. We always want to be monitoring for any new pathogen coming in. So we have a very brilliant whole genome sequencing capacity in Ontario that will assure us that we're not having new variants that are vaccine escape, and that the therapeutics will also be able to provide effective care against these new strains. So I hope you're hearing in my tone that we want a balanced, proportionate, a reasonable approach to public health measures going forward. There are significant lessons learned over the last 2 years. Sam's going to reinforce some of the negative and unintended consequences of public health measures. I want to assure you I'm very sensitive to them, and sensitive to always applying anything we put in from a public health measures vantage point with an equity lens, understanding its impact cross-culturally, across social demographics, and certainly our immunization strategy, testing strategy has always taken into consideration First Nations, Inuit, Métis status, knowing that we have to understand their risk, potentially increased risk for adverse outcomes associated with this virus. So lots of lessons learned, and I hope we will, in real time, adopt them and integrate them into our policy making at a provincial level. And I will stop there, David, and hand it over to you as the coordinator of this conference.
Thank you very much, Kieran. That's very helpful indeed. I'm going to now move to Sam Buttemer, and meanwhile, I am collecting. We may not get to all of these questions with answers, but I do want to express my gratitude to those who are posing these questions, and I will allude to them after Sam has finished her presentation. So, Sam, over to you.
Thank you, David. Let me just get this set up so that I can see my notes at the same time. So for those of you who attended last year, you'll remember that I spoke about some of the unintended consequences of the decisions that were being made with regards to management of the pandemic. And today I've decided to pivot a little bit and speak a bit more about what I'll call the wind down, which is basically the idea that it's very clear when a new pathogen emerges, particularly one like COVID that had potential for such substantial ramifications on our population, that strong interventions are needed and we have to start. And so the start point maybe was a little later than some of us would have wanted to see, but it was really clear in general in the span of kind of a month or two what needed to happen, and we kind of went from 0 to 100, and now we have to put on the brakes. Because like Kieran said, the actions that were being taken earlier in the pandemic are not necessarily appropriate for the stage of the pandemic we're at now. But how do you do that? How do you wind down in a way that manages the risk and also encourages return to the benefits of society that we've had restrictions on for so long? And also, how do we change our mindsets about it? Because we've been primed to be fearful some people less so. But in general, in society, we've been primed to be fearful of this. And how do we change our mindset about how we think about COVID? Because it unfortunately is not going to be leaving us anytime soon. As Gerald mentioned, there really isn't any hope of eradication of this virus. So a couple disclosures from me. I'm paid and employed by Queen's University. I do some contract work with the CPSO and UBC, but I generally avoid industry events or industry-sponsored events. I'm presenting here from my home in Kingston on the traditional lands of the Anishinaabe and Haudenosaunee, and I sincerely appreciate the opportunity to live and learn and teach from these lands. And I'm committed to ongoing anti-racism and anti-oppression work in what I do. So question one, Gerald already answered this. Is COVID going away? No, it's not. It's not going anywhere. And so you have to move on to the second question. And this is the more important question, because unfortunately, the first one is just not really negotiable. We've succeeded at eradicating two diseases from the world, one in cows and smallpox, and that's it. So we haven't succeeded at eradicating, every other disease that causes humans problems, and this one is not going to be the next one added to the list to be eradicated. And so we have to shift our mindset around coexisting. I want to make it clear, though, that coexisting does not mean give up. Okay, so some people are saying, well, why should we stop trying? We just shouldn't do anything. We should just let it rip. Well, that's not really what I'm saying here. We do need to continue some elements of containment. It's just that how we react is different because the situation is different. Fundamentally, as a public health physician, and in general, individuals working on policy in this area need to be thinking about the given risk at any given moment in time and decisions made based on that risk. And the risk now is just fundamentally very, very different than it was in March of 2020. So the public health approach at this point really needs to be focused on the aims rather than the society's fear around COVID or eradication. We really need to think, what are our aims and our responsibilities? And our responsibilities at this point are to continue to reduce morbidity and mortality of both COVID on the population and impacts of reaction to COVID and everything else. As a public health physician, I'm also very keenly aware that we've been seeing more opioid-related overdose deaths in the past 2 years. We've been seeing substantial impacts on mental wellness, particularly in individuals who are working in the health system and working in education systems, and parents. And those are worth considering as well. And then finally, we also need to consider the reduction of the strain on our health system. Fundamentally, and I'll speak to it in a second, our health system is not designed for any surge, not just COVID surge, but any surge. We don't have capacity for surges. And this is no different. And unfortunately, it means that our response needs to be more aggressive because we don't have the capacity to deal with the consequences. So we need to consider how we're going to achieve this reduction in morbidity and mortality and reduction of strain on our already very strained health system. And so from the public health perspective, COVID specific, excuse me, there's a few different things that we need to do. The first one relates to vaccination. I think Kieran and Gerald both gave very strong evidence that vaccination is a key part of our efforts here. It is not a sterilizing vaccine. It doesn't completely prevent acquisition and transmission, which is part of why it will be impossible to eradicate. But regardless, it substantially reduces the morbidity and mortality, and it does substantially still reduce transmission. And so when we're thinking about tools, that's an excellent tool in terms of reducing transmission of an infectious disease. And the picture I chose here, I chose the world in particular because as Gerald said, it's transmission of virus and virus replication that leads to mutations. And so we need to ensure that our worldwide population, our global population, has access to high quality vaccines to reduce viral replication and to reduce the chances of new emerging strains of COVID. Because fundamentally, if we don't do that, then we're not going to necessarily see improvements. Now, there is likely in a lot of the world's population some element of what people call natural immunity post-infection, even post-Omicron, because Omicron has really ripped through the world's population in a very short period of time. But we don't know how effective that is yet. We need more time to know how effective that is at reducing your chances of acquiring Omicron again, or a similar strain that is similar, which could then mutate into something that is then, evades immunity. So fundamentally, our best chances is to provide people with vaccine-mediated immunity, and we need to be doing more. So from a Canadian perspective, we need to be doing more and contributing to that global effort. The second thing is regards to testing. So testing is always, as a doctor, even working clinically, I only order tests that I'm going to act on. If I'm not going to take action or not take action, depending on the results of a test, I shouldn't do it, right? And at this point, Omicron is so prevalent within our society that for most, it's not going to change management if you get a positive test. You're still expected to stay home and self-isolate with symptoms because we know the transmissibility is so high, and even if it wasn't Omicron, the last thing anyone else needs is to get a runny nose, because then they're going to think they have Omicron, and then it ends up being a bit of a vicious cycle. And so it actually has been, because we are not going to change management based on testing, it's no longer necessary to test. And testing uses resources, right? We have a lot of healthcare workers that have been working at Beach Grove who, the amount of effort to go into testing is dramatic, and that's effort that can be placed elsewhere. And our health system is strained. So those are healthcare workers that we could use in other ways. And that's probably, I wasn't the person who decided to get back on testing, but that's probably a big part of why that pivot has happened. And I think actually from a public health perspective, it's very reasonable. So we're going to continue testing in places where it's going to make a difference. So people who would qualify for antiviral testing, people who are immune compromised, there are individuals, those individuals need access to testing and can still access it. Same with the healthcare workers. We obviously don't want healthcare worker transmission, because at this point, we can't afford to lose more healthcare workers in the workplace. And so we don't want them transmitting to each other. So it's important that they know if they're positive. And also they work with individuals who are at high risk. And so it's important for them to not transmit illness. Although, as Gerald will often say, typically the spread in healthcare settings is actually when healthcare workers take their masks off to eat lunch together in a side room. It's not actually when they're using PPE appropriately, because PPE is very effective. And so the other thing about testing is that we are still doing enough testing. We're still doing actually a remarkable number of swabs in the KFLNA region. I think we're, testing at a rate similar to what we were doing in October, even with the restrictions on testing, because so many people were symptomatic. And so we're still actually getting a lot of samples that can then go to the lab to get things like whole genome sequencing done and variant testing done to make sure we're not seeing anything new emerging. And that kind of surveillance is really important. And from a Canadian perspective and a global perspective, that sort of surveillance for new variants is going to be key, but we are doing enough tests to be able to catch that sort of thing at this point. So the other benefit of action without testing is that I think we're actually seeing a reduction in transmission of viruses in general right now. I told people this yesterday. I'm still shocked by this. I have a young toddler who is in daycare. She's been going to daycare for 3 weeks straight and has not come home with a runny nose once. And that is unheard of. I think if you talk to most parents of toddlers, they're constantly dripping, but she hasn't been, because she hasn't been exposed to anyone with symptoms, because you're not allowed at daycare with symptoms right now. And so I was actually really worried when the policy was put into place. I was like, oh no, she's going to be constantly at home for 5 days straight. But we've seen a reduction in spread, at least in her daycare. And I think it'll be interesting to see what we see kind of on a societal level with regards to other viruses and transmission in adults and in children. And I think there's probably a role for us to do a better job staying home when we're sick. And I'll speak about that in a minute. And so finally, moving on to the last kind of public health action is screening. Again, it kind of plays into what I just said before. We really need to be aggressive about keeping people home when they're symptomatic. We know this virus spreads, but it can't spread if you're not in the same place, right? If you stay home, you're not going to spread it to people you go to school with. And so we need to be aggressive about encouraging people to stay home when they're sick. And unfortunately, we have some structural barriers to that at a societal level. And those are things that we need to be addressing. And I'll speak to that in a second. So what else can we do? Well, our health system is currently in a crisis state. It's been underfunded for years. And even before 2020, if you talk to any of us, we would have told you that the hallway healthcare issue was dramatic and problematic. Every year we were worried about influenza because we couldn't handle the surge from influenza. We were not prepared for any level of healthcare surge in usage needs. And what we're seeing with Omicron right now is that hospitals are admitting a lot of people who have exacerbations of chronic problems when they contract COVID, things like heart failure or COPD. And they end up recovering well, but they need hospitalization. And our hospitals aren't set up to be able to provide that kind of surge in hospitalization support. And so we need to tackle the underlying health vulnerabilities within our health system if we want any chance of riding out further waves without societal restrictions. So what does our health system need? Well, we need more trained staff. Right now, we're losing staff by the droves, partly because of policy decisions at the provincial level that are not valuing staff as highly as they should. I think we can all see the bill that restricted raises for public workers, which ended up including a lot of healthcare workers, has significant ramifications, both on people choosing to stay in their jobs, but also their sense of feeling valued for what they do. Many healthcare workers are saying, I'm not appreciated in this role, I'm not valued, I'm leaving. And that's obviously not good. We need more healthcare workers, not less right now. And so we need to consider, how can we increase training? How can we have roles like nurse extenders or physician extenders to help manage more patients under one staff? But also we need to consider what our public policies are doing to impact this, and consider that inflation has been rising much faster than the current wage increases have been offering. And that essentially results in people making less money each year. So it's the anti-raise, which is not really something that's going to encourage people to stay in their roles. So we need to really deeply consider how we're going to address our healthcare workforce issues. We need surge capacity. Surge capacity is not physical beds, although physical beds are important. Surge capacity is more so around staffing, and that is the main part. We also probably need more home care options. We have a lot of people in hospital who are alternate levels of care, who would be better suited to a different care environment, but unfortunately there's not enough supports within our community to offer that. It's very hard to increase home care access when already we're at a staffing shortage. So again, we really need to examine what we're doing in terms of staffing, but we can also consider what technology we can reorient towards supporting people to stay at home. What kind of supervision can we provide people, that sort of thing. And consideration of reorienting our system towards efficiency. Many people within the public health sphere in particular saw lots of layers of bureaucracy within the public health response. And is there a way to restructure our public health system, not our healthcare, our public health system, to deal more efficiently? And also thinking about Ontario Health and OHTs, what can we do to reorient our Ontario Health teams to be more outcome oriented and more efficient in care provision? Those are some big questions that I spend a lot of time thinking about and talking about with my students in my health policy class, and I don't have answers, but I think they're things that we need to be thinking deeply about. In terms of what society needs, we need people to be allowed to stay home when they're sick. We still don't have paid sick days. It floors me whenever I think about it, how we've disincentivized people to reduce their transmission. And that needs to become at a societal level. You can't, a medical officer of health can't dictate that. You can't dictate job security. That needs to come at the provincial level. And I continue to call out for that from our premier. I'm not sure, there may be deaf ears, but I think that that's something that we all need to consider societally, that not allowing people to stay home when they're sick perpetuates transmission of disease. That's why we get sick. We also need to ensure people have housing, high quality housing. A lot of the transmission we were seeing with COVID was happening in very densely inhabited households with many people living in a small space, and it's not appropriate from a disease transmission perspective, but also from a humanitarian perspective. And we need to consider how housing impacts disease transmission. And finally, we need to keep our workplace flexibility. So for instance, last term when my daughter was sick, I was able to teach my class, 1 week via Zoom, right, instead of teaching in person. And having that sort of flexibility is going to be really important in workplaces in order to ensure that people can, again, reduce their contacts when they're symptomatic or contacts of symptomatic individuals. And finally, the public education system. I think we need to recognize that schooling is fundamental for children for a variety of reasons. And I think that message didn't always come through in the past 2 years. It's important for social development. It's important for lifelong trajectory in terms of kind of income potential and poverty reduction. And it plays a societal role in terms of parent workability, particularly for women. So it is a gendered issue. We also need to consider why our province has not yet worked with the feds on universal childcare. That's also a major issue and a major barrier for people. And finally, we also need kind of some societal changes. So like I said, minimum wage increases, affordable housing, structural changes to policies that disproportionately affect oppressed groups in our province and in our country, and more access to opioid agonist therapies and decriminalization. Like I said, we've been seeing more and more opioid related deaths, and that is getting forgotten as well, but it is a major problem. So I decided to end with a picture of a wave, because fundamentally we're going to keep seeing waves. What we can expect to see, in my best guess, I'm not a fortune teller, but what my best guess is that we're going to see waves seasonally, because COVID, along with other coronaviruses, tends to be a fairly seasonal virus in that it tends to emerge more in the fall. And we can expect that we're going to see more variants. Unclear how much protection we're going to have against those variants, but probably a decent amount. But we're going to need to protect the people who are most vulnerable again. So we're going to need to have vaccination booster campaigns for healthcare workers, for immune compromised people, older adults, in the fall, potentially with variant immunity incorporated. We'll see. We're going to need to make sure that we all continue to support each other by staying home when unwell, and reducing contacts when we're sick, even if it's not necessarily societal rule. And we're going to need to kind of reframe how we think about infectious disease, because even if COVID tends to not cause as much of a problem next winter, I promise you influenza is waiting in the wings for its chance to spread again. And it will be a bad flu year instead. And we were kind of inured to the idea of flu being bad, but I can tell you from a hospital perspective, every year it is bad. And it causes us substantial problems. And we've never shut society down, in the past, 100 years for influenza the same way, but it presents substantial risks similar to COVID, and we need to be thinking about that too. So those are some of my thoughts. I could talk for longer, but fundamentally, I think we really need to pivot our thoughts on, how do we stay with this for a long period of time, and what can we change in terms of our societal structures to support us in living with COVID in a way that doesn't cause nearly the same amount of societal disruption, because it's not necessary at this point.
Thank you, Sam. Thank you very much. And to all of you, we have an array of questions, which I know we will not get to all of, but if I might direct a couple. We've heard from Gerald that the biggest predictor of danger from COVID is age, and of the importance on the other end of the spectrum of education and social development for children. However, I think all of us continue to be worried about the safety of our children in daycare, in schools, in universities as they grow up. And so there were many questions centered about, first of all, when or should there be vaccination for the kids under 5, or third doses for teenagers? But more specifically, testing in schools, and how can we be reassured that schools are safe? So I wonder first, Gerald, could you speak very briefly about this again, about our younger generation and the risks that we may or may not perceive to them. And then Kieran, perhaps speak again about schools and your views and opinions and advice to government on the safety of schools and the importance of education. So first to you, Gerald.
Yeah, there's all great questions. So the data we're still gathering on the under 5-year-olds, I did answer that I answered about 12 questions while everyone was chatting there. The data from them is showing really what looks like a more marginal benefit, again, because age is so important. People have to understand that children are different. I mean, my pediatric colleagues talk about that all the time. Kids are different. And kids' immune systems are very different and very much more robust than you see in older people. So third doses for the sort of 12 to 17-year-olds, that's coming. I can't tell you when. But again, when you look at anyone under the age of 20, on a population basis, there is really a lot less risk in that group, a hugely lot less risk. And the problem that we have in a stressful environment like a pandemic is I can show you population data, but you can have a story, or you can have seen something on social media about somebody's child who perhaps died, or perhaps has some long-lasting symptoms. And your brain has a hard time reconciling that we know on a population basis, children and adolescents and youth do not get severe COVID anywhere near as frequent as older people, but that will be offset by your own personal experience or the experience you may have heard through various kinds of media, et cetera. I'll just briefly mention that the rapid antigen test, which was a big thing, I would say, about a month or so ago, we now have pretty compelling data that they're not as reliable in terms of sensitivity in detecting Omicron as they are with the other variants. So one of the challenges we have is rolling out lots of tests, but a negative result in the first few days of infection isn't really helping you because it's a falsely negative test, really puts the whole testing strategy with rapid tests a little bit more challenging than we thought. And this is just data that we've seen in the last couple of weeks in looking at the overall performance of those tests. So I'll leave it over to Kieran to talk about schools.
Thanks, Gerald. Kieran?
Schools, our approach, given Omicron, is not risk elimination. That's impossible. As the other speakers have mentioned, it's a risk reduction. So I do believe we put in significant safety measures in our school that have reduced the risk. It's never going to be zero of Omicron. And Gerald's already said that the risk of severe outcomes in children is very, very low, especially relative to our older population. So you're reducing a low risk to even lower by the measures that we put in place. And that includes the $600 million investment in improving airflow, ventilation, filtration, the screening that takes place, the access to 2 negative RATs 24 hours apart if you're symptomatic with symptoms similar to COVID, plus the cohorting, the masking in that environment. All of those measures, I do believe, are safer than our children being elsewhere in the community, which happens often during school closures. So I do believe our schools are as safe as they can be. It's a risk reduction, not a risk elimination strategy. And I would, for any parent, the level of activity in a school will reflect that activity in the community. So absolutely, there are cases, but there are steps that every person can take, from masking to hand hygiene to distancing to symptom screening to testing if and at home with the RAT tests. And two negatives 24 hours apart would be non-COVID and not need any further screening. So it is always about having a balance. I think our children, mental, physical, social, economic, educational needs have been put weren't an immediate priority in the early closures, and I think we've all realized as a society that we have to preserve in-person learning as much as we can, whether that's for all education, including elementary, secondary, and post-secondary.
Thanks, Kieran. And as people now know, I think our university and all other universities in the province are moving rapidly now toward back to in-person activities, academic and otherwise, during the course of February. I have a question for Gerald, and then maybe we should do a last question to Sam because we're running out of time. Gerald, there was a person wrote, there've been worries that we've seen people die in our local community. We've seen tragic deaths. Some 20 odd people have died in Kingston Health Sciences Centre. The question was, can you reassure us that in our, or whether it's in Toronto or Hamilton or any of our hospital settings, are Ontarians getting state-of-the-art care for their COVID? How do we know that? Whether they're admitted through the emergency department for a few days of oxygenation, or tragically, if they have to go to more intensive interventions like ventilation and ICU. How are we doing in that regard?
We're really state of the art. The only thing that we're challenged at the moment with certain numbers of these drugs and treatments available is a supply issue. The United States is a huge vacuum sucking sound, and they basically manufacture and hold on to a lot of these treatments. But we have a supply. We use it very effectively. We have been able to use it to really protect and save many lives. I know I can speak to that personally here at our own hospital, but I know it from my colleagues across the province. People have to understand that when you come into hospital with anything, a broken hip or whatever, and I know I'm speaking to the converted amongst my panelists here, all of those things are really relevant factors to the idea of if you're going to survive or not. So I think we really have to understand that. There's this sort of concept that an 80-year-old who's very healthy comes into hospital and dies of COVID, that must be a failure of our treatment, and it isn't. It is a fact of life, unfortunately, and age is a predictor, as the actuarials will tell us, of the likelihood of you passing away. And hospitalization comes with all kinds of other risks that are associated with it. So yeah, no, we really do provide great treatment. We've done an amazing job with lots of patients. We are now taking patients again from other parts of the province here in Kingston. And the care that we're providing is as good, if not better than some of the treatments you might get in overcrowded scenarios in high-tech countries like the United States.
Thank you, Gerald. And yes, all of us, particularly I, am acutely aware of the advancing risk with advancing age. Thank you very much for that reminder. Sam, last question to you. When will we know that we've moved from pandemic to endemic? Will this be Kieran's announcement on a certain date? Will it be a headline in the Globe and Mail and the National Post? Canada now endemic, no longer pandemic. How will we know?
No, there's not going to be a point in time. There's not going to be a flag that goes up. I always think about, I don't know anyone who remembers this, back in the early 2000s when George Bush was standing on the on that boat and with the sign "Mission Accomplished." We've solved the problem in the Middle East. Obviously, that didn't happen, and that's kind of what I think about with regards to. With COVID, there's not going to be a mission accomplished sign. And if we put it up, we're going to be wrong about it anyway. Realistically, we've already started to move towards endemicity. We can see that with Omicron, our wave has resulted, while in many more infections, much different impacts on our health system. And we also know that, again, because we're seeing sustained transmission or possible transmission among individuals who have previously been infected, that this is probably something we're going to continue to see, right? And that makes it more of an endemic illness. But truly, pandemic and endemic aren't really words that go against each other. Pandemic is a word for an outbreak that's across the world, across borders, and endemic is something that is kind of constantly being spread. I think what we're going to see is we're going to see constant spread, but we're going to see peaks and valleys, right? And it's going to be like the waves I talked about. So some waves, like our earlier waves in COVID, are going to be really big, and some of them are going to be much smaller blips. And I suspect over the winter, we probably will see a bit of a bigger wave, and it might coincide with influenza in a way that's going to be hard on us. But I don't think that we're going to be seeing waves that are as big as what we saw earlier in COVID. I think we're going to see smaller and smaller waves with time, which is more and more consistent with endemicity.
Thanks, Sam. Well, it's time to draw this to a close. I hope I have your agreement that you will join me 365 days from now when we will do 4.0. I appreciate the theme of optimism and constructive approach to this today. I hope our audience has tolerated us once again. Thank you to everybody who's asked a question. I'm sorry we didn't get to answer them all, but most of you know how to find us one way or another. Sam, thank you specifically for what you said. Kieran, keep up a good work with advising the nation and looking after people in the hospital. And Kieran, you have our affection and attention as you keep guiding the province in the right path ahead through this challenge. Thank you all very much indeed.
Thank you.
Thank you, David.